Hello everyone. Today I'm going to speak on the topic caries detection tools and assessment. The caries detection tools are broadly classified into in vivo methods and in vitro methods. The in vivo methods include visual examination, tactile examination, radiographic methods like digital radiography, fiber optic transillumination, optical methods like fluorescence, light scattering, electrical resistance method, ultrasonic methods, and dyes. The in vitro methods are classified into single tooth measurements and methods for sequential measurement on tooth slabs. Under single tooth measurement comes chemical analysis, cross-sectional microhardness, etc. Methods for sequential measurement on tooth slabs include iodine absorbitometer, longitudinal microradiograph, etc. So coming to the fiber optic transillumination, it was described by Friedman and Marcus. It is a useful tool for the detection of caries, soft tissue lesions, and calculus. It permits the use of a cold high intensity light source that can be used anywhere in the oral cavity with ease and flexibility. So the principle of fiber optic transillumination is that there's a difference in index of light transmission of the decayed and the sound tooth. If you look at this picture, we can see that during FOTI or the fiber optic transillumination, because of the difference in the index of light transmission, the caries area will appear darker than the rest of the tooth structure. So the principle is the difference in the index of light transmission. The decayed tooth will have a lower index of light transmission compared to the sound tooth, because of which it will appear darker on fiber optic transillumination. The advantage is that it can be especially used in the anterior region with ease and flexibility. However, it's a little bit difficult to use in the posterior region. It is advocated as an adjunct to radiograph and visual methods. It is used for caries detection where the proximal decay is adjacent to a radiopaque restoration. Some of the limitations is that it cannot be used on the posterior teeth and on the approximal surfaces, and it cannot be used for the diagnosis of secondary caries. Another recent advancement of fiber optic transillumination is the digital image fiber optic transillumination. It is an effective tool for the early diagnosis of the dental caries and assessing its progression without the need for ionizing radiations. So the light from the probe is positioned on the tooth to be examined, and the reflected light is collected by another probe. And this is measured using a charge coupled device camera, which is connected to the computer, which puts up a value. That is the principle of digital image fiber optic transillumination. So the digital image fiber optic transillumination has the potential to detect early caries lesion and assess their progression. So the question that was asked from this part was the FOTI method, that is fiber optic transillumination method of caries diagnosis, is based on the principle of what? I've already told you it's based on the principle of difference in the index of light transmission. Coming to Diagnodent by Lucy, it is based on the principle of fluorescence. The system has a range of 9 to 99, out of which 9 indicates the healthiest tooth structure. So the principle of diagonodent is that I told you it is based on the principle of fluorescence. The first part, that is a fiber optic technology. Here the device uses a fiber optic probe that emits a light of a particular wavelength, which is 655 nanometer, and this is directed onto the tooth surface. The second part, detection of the reflected light. A second optic bundle detects the reflected fluorescent light from the tooth of interest, and this reflected fluorescent light will based on the degree of level of demineralization will have a different wavelength that is measured by the computer, and it puts up a value on the monitor. This is the principle of diagonodent. So this is the cutoff value for diagonodent. The values between 0 and 13 indicates that there is no caries. The value between 14 and 20 indicates there is enamel caries. The value between 21 and 30 indicates there is dentine caries. And the values greater than 30 shows that operative care is advised. So coming to the principles and concepts of cavity preparation. We know the Black's classification from class 1 to class 6. Black's classification class 1, that is occlusal caries on the facial and lingual surface of molars and premolars, occlusal two-third, lingual surface of maxillary anterior teeth, all comes under class 1. Class 2, proximal surfaces of the posterior teeth. Class 3, proximal surface of the anterior teeth without involving the incisal edge. Class 4, proximal surface on the anterior teeth involving the incisal edge. Class 5, lesions on the cervical aspect of the tooth on the facial aspect of the anterior and posterior teeth. And class 6, which is a modification given by J.W. Simons, that is involving the cusp tip and incisal edges. Coming to the Baum's classification, there is the pit and fissure caries and also the smooth surface caries. Those are the two components of the Baum's classification. The classification by Mount and Hume, this is the classification based on the site of the caries lesion and the size of the caries lesion. Based on the site of the caries lesion, it can be site 1, 2, 3. Site 1 is pit and fissure caries on the occlusal surface of the tooth. Site 2 is proximal surface caries below the contact. And site 3 is cervical caries. So based on the size of the caries lesion, it is again classified into size 1, 2, 3, 4. Size 1 is minimal involvement of tendon. Size 2 is moderate involvement of tendon. Size 3 is enlarged cavity. And size 4 is extensive involvement of dentin. So this is the chart and the values prepared on the basis of site and size. If the site is site 1, that is pit and fissure, and if the size is 1, the value assigned will be 1.1. Just like that, if the site is on the cervical, then we move on to 3, and depending on the size, if it is moderate, it will be 3.2. Coming to the methods available for isolation, there are the direct methods and the indirect methods. The direct methods include use of rubber dam, cotton rolls, gauze pieces, absorbent water, suction devices, gingival retraction cord. Coming to the indirect methods, it includes comfortable positioning of the patient, using of local anesthesia, anti-sialagogues, anti-anxiety drugs, muscle relaxants. These are the indirect methods. Now, a term for you to remember, that is the rebound response. When we use a slow speed burr, then for cavity preparation, there will be vibrations created in the cavity. This can result in the rebound response, which is characterized by pulpal edema, fibrosis of the pulp tissue, changes in the ground substance, and reduction in the predentin formation. So coming to rubber dam, which was introduced by S.C. Barnum in 1864. The parts of a rubber dam includes the rubber dam clamp is there, the rubber dam forceps is there, punch is there, scissors, lubricants, frame, sheet. You just need to remember the parts of the rubber dam. Then the rubber dam sheet is available in different thickness. There is the thin, medium, heavy, extra heavy, and the special heavy. The thickness of thin is 0.15 millimeter, that of medium is 0.20 millimeter, that of heavy is 0.25, that of extra heavy is 0.30, and that of special heavy is 0.35. That is 0.15 to 0.35 is the range. Just add 0.05 to each one of them. The different sizes of rubber dam sheet that are available is the 5 into 5 and the 6 into 6. So the 6 into 6 rubber dam sheet is used for adults, and the 5 into 5 rubber dam sheet is used in pediatric dentistry. So in the primary dentition, the rubber dam sheets are primarily placed over the canines, primary and first molars and the second molars. Now how to place the rubber dam on the maxillary arch? So the first hole is punched 1.25 inches, that is 3.5 centimeter from the upper border of the rubber dam sheet, and that hole is for the C canine. The second hole is punched 4 to 5 millimeter away from the first hole, and it is smaller in size than the first hole at an angle of 40 degree to the vertical. The third hole is punched for E, which is again 4 to 5 millimeter from the second hole, and it will be smaller in size than the second hole, again at an angulation of 40 degree. Just like that, for the mandibular arch, the first hole is also punched for C, which is 1.75 inches from the lower border of the rubber dam sheet. The other one, it was 1.25 inches. The second and the third hole is for the D and E, that is 4 to 5 millimeter from the respective holes. Coming to the things that we have to keep in mind during cavity preparation in primary teeth. So the class 1 cavities, because of the narrow occlusal table, the isthmus should not be more than one third the intercuspal distance. The depth should not be more than 0.5 mm into the dentin. The pulpal floor should be kept as flat as possible. These are things that you have to keep in mind while preparing class 1 cavity on primary tooth. The occlusal table, because of the occlusal table is narrow, the isthmus should not be more than one third the intercuspal distance. The depth should not be more than 0.5 mm into the dentin, and the pulpal floor should be kept as flat as possible. The things that you have to remember during class 2 cavity preparation, the box shape should provide the box shape that is created by the occlusal convergence of the buccal and the lingual walls should be kept parallel to the external surface as well. The gingival floor of the proximal box in class 2 should be placed in self-cleansing areas, either below the contact or depending on the extent of the caries. The gingival seat should be left unbeveled because because of the direction of the enamel rods. In case of adults, the enamel rods are directed occlusally, because of which they are unsupported and we need to bevel them. Whereas in case of children, the enamel rods are directed downwards. So there is no unsupported enamel rods and we do not need to bevel them. The width of the isthmus should not exceed one third of the intercuspal distance. The axiopulpal line angle should be rounded tunnel or groove. The advantage of rounding the axiopulpal line angle is that we get more thickness of the restoration at that axiopulpal line angle if you round it. Because most of the failure of class 2 restorations in primary dentition takes place at the proximal box, especially at the axiopulpal area. So in order to increase the thickness of the restoration in that area, we have to round off the or create retentive grooves in the axiopulpal line. So we should take care near the pulp, particularly in the mesiobuccal portion of the primary first molar, because during cavity preparation, this pulp horn, mesiobuccal pulp horn of the primary molars can get exposed because it is at a higher level compared to the remaining pulp. The proximal wall should be kept in a way that there is enough clearance with the adjacent tooth. The explorer should be able to freely pass between the teeth. So these are things you have to remember when preparing class 2 cavities. So the Glasshammer cement by Wilson et al. In 1970s. The advantage of Glasshammer cement is that it is a two-colored restorative material. It is capable of chemically bonding to the tooth structure and it is capable of releasing fluoride, which can help in remineralization to a certain extent. The powder is calcium fluorosilicate and the liquid is polyalkyonic acid. So coming to the modifications, some of the modifications of glass enamel cements, there's the anhydrous form, that is the liquid is freeze dried and it is incorporated into the powder. Then there is the resin modified glass enomers in which photoinitiators are added. Then there is the nano ionomer which have increased wear resistance compared to the traditional glass enomers. Then there are the compomers to incorporate some of the properties of the glass enomer cement into the composite compomers were made. Now, what is tunnel cavity preparation? If the cavity is very small and it is 2.5 mm from the crest of the marginal ridge, you can prepare a tunnel cavity. Coming to some of the restorative materials that are used for in pediatric dentistry, there is the passive restorative material and the active restorative materials are there. Passive includes the GIC, resin modified glass ionomers, composites and compomers. Whereas the active restorative materials used include smart composites, Ariston PHC and ACP composites. The ACP composites are called smart composites because when the pH falls below the critical pH of 5.5, demineralization is supposed to take place. But what happens with ACP composite is that when the critical pH falls below 5.5, the ACP composite starts releasing amorphous calcium phosphate that will supersaturate the saliva with hydroxyapatite and prevents demineralization, instead promotes remineralization. Now what are strip crowns? Strip crowns are the crowns that are filled with a resinous material like composite. Then they are bonded onto the tooth and the crown form is then removed. Here in this picture, you can see that these transparent crowns will be filled with composite. Then they are bonded onto the tooth. Once the bonding process is complete, the crowns are then simply removed. Whereas in pedo jacket crowns, it is a tooth-colored copolymer material which is filled with the resin and left onto the tooth after the polymerization process is complete. That is the difference between strip crowns and pedo jacket. Pedo jacket crowns, they are tooth-colored already, and once they are bonded on the tooth, they are left on the tooth and it is not removed. Now let's discuss some of the questions that were asked in the previous year. The pulp horn that is most likely to be exposed during cavity preparation on deciduous molar is. I've told you earlier, we should be careful while working on the primary first molar because the mesiobuccal pulp horn of the primary first molar is at a higher level, and during cavity preparation, this pulp horn may get exposed. So the answer for this is the mesiobuccal of the first molar, option A. Now, the second question, a 9-year-old child is having recurrent pain in the lower right molar region with fever from last night. Only proximal caries in the primary first molar is present. So the way to proceed is whenever we come to a conclusion that the patient is having irreversible pulpitis, we should confirm it with the help of the taking a radiograph. So the first step that we have to do when a patient reports to you with pain is take the radiograph. So the answer is option A, IUPF first. The most common cause of failure of class 2. I've told you earlier, in pediatric children, then in children, the most common cause of fracture of class 2 restoration takes place at the proximal box, that too at the axiopulpal area. Because if there is not adequate thickness of the restoration, that fracture will happen at the axiopulpal line angle. So either we round it off or create retention grooves. So the answer for this is B, proximal box fracture. GIC is done for primary teeth mainly because of the advantage of GIC. I've told you earlier, it is a two-color restorative material. It is fluoride releasing. It can adhere to the tooth surface. So for the answer for this is all of the above. Question number 5. In primary teeth, gingival seat in a class 2 preparation is left, unbeveled, beveled to remove unsupported enamel rods, beveled same as permanent tooth. I've told you that the direction of the enamel rods for primary dentition is directed, it is directed downwards, because of which there are no unsupported enamel rods, unlike the enamel rods that are seen in permanent dentition, which are unsupported and they have to be beveled. But for the primary dentition, the gingival seat should be left unbeveled. The answer is A. Question number 6. Stainless steel crown was introduced for the construction of orthodontic appliances by Burstone. You have to remember that by heart. To prepare a cavity on a mandibular first molar child, we should give. So in order to prepare a cavity, especially on the molars, just giving infiltration is not enough. We need the pulpal anesthesia, for which we have to give an inferior alveolar nerve work with a long buccal nerve work. The option is C. Question number 8. The proximal walls of class 2 cavity on a deciduous molar. The proximal walls of the class 2 cavity on a decimal molar is supposed to provide retention for the restoration. So they should converge towards the occlusal surface. So the answer is option B. All of the following are chemomechanical methods of caries removal except. So air abrasion is there, Carisol, Carides and papacarin is there. Except air abrasion, all others are chemomechanical methods of caries removal. All of them stains the tooth and they identify the infected dentin and the selectively removal of the infected dentin is removed. Done. That's why they are called as chemomechanical methods of tooth caries removal except air abrasion, which is a mechanical method. So the answer for that is A. Question number 10. The rubber dam is particularly adapted to the primary second molar because options include occlusocervical height favors its retention, cervical constriction of the crown, mesiobuccal bulge, smaller diameter of the crown. So the answer for this is the cervical constriction of the crown favors its retention. So if you look at this diagram, this is the cervical constriction that is seen for the molars. Because of this cervical constriction, the clamps are easily able to engage them and they will not get dislodged. So the answer for this is the cervical constriction of the crown favors its retention. Question number 12. Chemotherapeutic plaque control method involves the use of flows, disclosing agent, dendriphizers, and sugar substitute. The answer for this is disclosing agents. Question number 13. The presence of higher amounts of proline-rich proteins effects on caries causation can have what kind of? The presence of higher amounts of PRP can have what kind of effect? The options are caries promoting since they have bactericidal adherence, make the tooth surface resistant to caries since it enhances fluoride action, has its role during tooth mineralization only with no effect on caries, aid in supersaturation of saliva, therefore make the tooth resistant to caries. So no. So what the PRP does is that PRP bonds to the hydroxyapatite in the saliva. Therefore, the hydroxyapatite is not lost from the saliva and the saliva becomes supersaturated with hydroxyapatite, making the tooth resistant to caries. So the answer for this is 13D. For next question, aspartame. Aspartame is a non-caloric sweetener, caloric sweetener, sugar complex, none of the above. Aspartame is a non-caloric sweetener. Coming to question number 15, fiber optic transformation method of caries diagnosis is based on the principle of what? I've told you it is based on the principle of index or difference in index of light transmission between the caries tooth structure and the sound tooth structure. Therefore, the answer is option C. There is different index of light transmission for decade of sound enamel. The arch criminal in caries is definitely refined sugars. Under this, the refined sugar in this group is the sucrose. So this is the caries activity test. This is classified into low risk, moderate risk, and high risk patients. Where we can say that the pediatric child is having a low risk caries when there is no caries present in the past 24 months, no enamel white spot lesions are there, when there's no visible plaque or gingivitis, optical fluoride exposure is there. That we can classify them as moderate risk when there is caries tooth in the past 24 months. One area of white spot lesion is present when there is gingivitis, suboptimal fluoride exposure, one or two in between sugar exposure between meals is there. High risk patients include caries teeth in the past 12 months, more than one area of white spot lesion is present, visible plaque, enamel hyperplasia, wearing of the orthodontic appliance, suboptimal fluoride exposure, active caries in months, 3 or more between meal exposure to simple sugar. So just remember that. Low risk, moderate risk, and high risk is there. Carisol, which is a chemomechanical substance used for caries removal, contains glycine and lysine. It does not contain 0.5 mg sodium hydrochloride. It has a pH of 7. It contains erythrosin dye. So the option is not D because erythrosin dye is seen in papacarin. No, erythrosin dye is seen in Caridex. Stop. Reshoot. It contains glycine and lysine. Question number 18. The cat in pediatric dentistry is option A, Caries activity test, Caries advancement test, Caries risk assessment tool, and the child aptitude test. The cat in pediatric dentistry is Caries risk assessment tool. The answer is option C. Question number 19. The Keys triad does not include time, substrate, tooth, and flora. The Keys triad consists of substrate, tooth, and substrate, that is the tooth, flora and the flora, that is the microorganisms, and the host. It does not have time. Time was introduced later on by Newborn. That is the fourth factor. Question number 20. Strip counts are indicated in pediatric patients with extensive caries in anterior teeth, extensive caries in posterior teeth, Ellis class 1 fracture, grossly destructed anterior teeth. So strip counts are indicated in pediatric patients with extensive caries in the anterior teeth, mainly for aesthetic purposes. Question number 21. Caries assessment in children, which one is not high risk factor? Reshoot. The answer for that is no initial demyelinization or white spot. Question number 22. The mother of a 10-month-old child came with a complaint of non-eruption of teeth. How will you perfectly sanitate the parents? So, normally in these days, the eruption of teeth of the children are delayed by 6 months. So, in such cases, a wait and watch approach is most ideal. Because of that, the answer for this is wait and watch, option A. Caries excavation using Carisol. Option A, conventional preparation design, clinical separation of sound and caries dentin. Option C, clinical separation of primary and secondary dentin. Option D, conventional rotary method of cavity preparation. So use of a chemomechanical method like Carisol is a clinical separation of sound and caries dentin. So the answer is option B. 24. On a primary second molar, caries occurs most commonly on the reshoot. Question number 25. The suitable technique used for diagnosis of posterior interproximal caries in children includes taking a bite win is ideal for detection of the caries. That too with an RVG would be very nice. So the option for answer for that is 25C, bite wing with RVG. So that concludes my presentation. Thank you.